Hi, my name is Solomon Culver, and I'm a hospitalist at The Ohio State University. This is the fourth in a series of lectures leading up to an analysis of the paper, Restrictive or Liberal Transfusion Strategy in Myocardial Infarction by JL Carson. The title of this lecture is Stratified Block Randomization and Statistical Adjustment. But before we get started, please go down to the bottom of your screen and like and subscribe. So usually we say that correlation does not equal causation, and that's typically the case. The thing that comes between correlation and causation is what we call confounding. And at its simplest, confounding describes the situation where you have two different groups that have different baseline characteristics. And then even if you give them different treatments and they have different outcomes, it's not really possible for you to conclude that the difference in their outcomes was because of the difference in treatment, or whether it could have just been that they had very different characteristics to begin with. And this is why we use randomized controlled trials. And that's because when you randomize patients to their treatment, then you're basically ensuring that those two treatment groups have the same baseline characteristics. In fact, the larger your sample size is, the closer those two baseline characteristics will be. So even though randomization is supposed to lead to balance between the covariates of the two treatment groups, that balance is really only perfect in an infinite limit. So because no clinical trial really has an infinite study population, no clinical trial can really claim to have perfect prognostic balance. However, investigators can help with balancing out certain risk factors by pre-selecting them and then stratifying the study population into layers or strata, each of which would have the same covariate pattern or risk factor pattern. And then each of the strata can then be individually randomized so that at the end of the day, those pre-specified covariates will be well balanced between the treatment and the control group. Another important concept in understanding randomized controlled trials is the concept of statistical efficiency. And this is a phrase that essentially means how much information you can gain from the study itself. Now, efficiency will increase as the sample size increases, so obviously studies with large sample sizes are better than studies with small sample sizes. But the absolute size of the study population is not the only thing that matters. It's also the way that those patients are distributed between the two groups. For instance, if there are a lot of patients in the treatment group and not very many patients in the control group, then it's not very easy to get a lot of information from the study because your enormous treatment group is being compared to a relatively imprecise estimate from that small control group. The most efficient way to design a study would be a study that would have equal numbers of patients in each arm. But randomization by its nature can potentially lead to imbalanced treatment groups, and when the sample size is relatively small, that imbalance could be fairly extreme. So block randomization refers to a strategy of dividing up the study population into subgroups of even-numbered size, which we call blocks. Then each block is randomized in such a way that exactly half of the block goes to each treatment group. Well, this strategy does not do anything for covariate balance or confounding, but it does ensure that the treatment group and the control group will end up with an equal number of patients. And the procedure does not threaten anything else about randomization. In practice, investigators will also often vary the size of each block so that some blocks are 8 or 10 or 12 patients in size. And the reason to do this is to prevent the clinicians who are enrolling patients into the trial from guessing at their patients' allocation and potentially unblinding the study. So most clinical trials will use a combination of stratification and block randomization. What this looks like is first they create the strata in which the patients will all have the same covariate pattern with respect to whatever the pre-specified risk factors are that the investigators are worried about. And then from each strata, the patients will be divided into a number of blocks of whatever size, permuted, even numbered size. Then each of these blocks will be randomly divided into exactly 2 subgroups. One of each will go to their respective treatment arm, and the end result will be a treatment and control group with the same number of patients, as well as covariate balance with respect to whatever the important risk factors were that the investigators pre-specified. So in a perfectly randomized study, there is prognostic balance at the outset, which is continued throughout the course of the trial. So the statistical analysis at the end of the study can be very straightforward. Investigators really only have to straightforwardly compare the outcomes of the control patients to those of the treatment group. Now, unfortunately, we don't really have perfectly randomized studies because they have finite populations, so there can be randomly imbalanced covariates between the 2 groups. And also, during the course of the trial, some things can happen. Patients can leave, they can cross over, and other things can disrupt the covariate balance which they had hopefully achieved at the outset during randomization. But since the investigators can really only do this trial once, and at the end of the study they're stuck with the data that they have, if they suspect that there is a loss of covariate balance or if confounding had been introduced in some way, what they can do is adjust for those confounders using regression analysis. And when they do this, what it can do is essentially mathematically recreate the population as though there had been covariate balance and eliminate some of the confounding which they may have picked up through whatever mechanism. So one of the assumptions that our statistical methods require for normal analysis is the assumption of independent observations. This means to say that in a clinical trial, if we want to analyze the outcomes of the patients, we have to assume that the outcomes of one patient will not directly impact the outcomes of another patient. And this is typically the case, but there are a lot of circumstances where this assumption can be violated. For instance, if there were multiple family members in the same trial, and one of them started to do badly on their treatment, then the rest of the family could maybe get anxious, stop taking their medication, be somehow influenced by the poor outcomes of the first, and then that would violate that assumption of independence. Another very common situation would be in a study where the individual patients have multiple observations over time. Each one of those observations, which call longitudinal observations, each one of those is not really independent of the others because a good predictor of future measurements would be the past measurements of the same patient. And then in another very common situation of correlated data, studies which are multi-center, meaning they enroll patients from multiple medical centers across the world. These have a lack of independence because patients who are drawn from the same medical center will have correlated outcomes because medical centers which are very good tend to have patients with good outcomes regardless of which arm of the study that they're on. And then hospitals or medical systems which maybe aren't quite the same level of quality may have worse outcomes overall, also independent of the treatment that the patients are receiving. So each one of these examples is a situation of lack of independence or data correlation, which causes a problem for our normal statistical methods. So when we have correlated data, then we have to keep in mind that there are 2 separate sources of variability at play, as opposed to the single source of variability that we see in data that's independent. First, we have the variability within units of observation. For instance, the variability of one individual's blood pressure as it's measured over time. But on top of that, we have the variability between units. For instance, the variability in blood pressure measurements between patients who are on a specific medication and patients who are not. And if we ignore those two sources of variability, or if we collapse them into one single variability construct, then it puts us at risk of making really potentially catastrophic inferences. And a great example of that is the figure here on the right, which is data from a hypothetical study of quality of life as a function of the number of weekly hours of exercise. And in this study, you can see each different color represents a different individual, and all of the data points of that color are the longitudinal measurements of that person's quality of life as they vary their weekly hours of exercise. And when you take this data all in aggregate, what it looks like is that the more hours of exercise per week, the lower your quality of life will be, which is counterintuitive. Instead, what we would like to see is the figure that is shown here, where each individual is seen as one specific unit, and the effect of exercise is isolated for each one of those units as a separate line. And when we do this, we can see that no matter what a person's baseline quality of life was or their baseline level of exercise was, there is a positive linear relationship between the hours of exercise and the quality of life within each individual person. Now, the type of mathematical analysis that allows us to do these inferences is called a linear mixed model. And, the concept of a mixed model, it's basically saying that it includes both the within unit and between unit variability, mixes them. These models are essentially required for any longitudinal study, like this one shown here, in which the patients have multiple measurements taken over time. But they're also important in multi-centered clinical trials, where the patient outcomes are clustered together based on the medical center that they received their treatment. So to summarize what we've talked about so far, medical centers benefit from stratification in order to improve the prognostic balance when we can't necessarily rely on probability alone to lead to equal covariate balance between the two groups. At the end of the study, we can also use statistical adjustment to help correct for any deficiency in prognostic balance, which may have arisen during the course of the trial because of loss to follow-up or crossovers or whatever. And then also, multi-center clinical trials benefit from blocking, which is a way to ensure that the treatment group and the control group have the same number of patients. And this allows us to get the maximum amount of information from the patients that we have. And then lastly, multi-center clinical trials have inside of them the problem of correlated data or lack of independent observations, because patients from the same medical center will have clustered outcomes. So in order to properly account for these correlations, it's really helpful for the investigators to use something like linear mixed models. So in the MINT trial, investigators wanted to see if increased transfusion goals would lead to improved outcomes in myocardial infarction. Like many good multi-center trials, the investigators used permuted block randomization, and they stratified with respect to the different medical centers. So the investigators first analyzed the unadjusted crude data, meaning they analyzed the outcomes without considering the correlations, the missing data, or the potential lack of covariate balance. And under this analysis, they calculated a relative risk of 1.16 with a 95% confidence interval from 1 to 1.35. Now, they then went back and used a linear mixed model to account for the correlations within the medical centers, as well as using mice to impute the data which had been lost from loss to follow-up and withdrawals. And this analysis gave a relative risk of 1.15 with a confidence interval from 0.99 to 1.34. Lastly, they reran this analysis with the linear mixed model, and they added as additional covariates a whole list of potential risk factors which could influence outcome, which also ended up giving basically the same result, a relative risk of 1.16 with a 95% confidence interval of 1 to 1.36. So what we can conclude from these numbers is that the MINT study actually achieved its goal of baseline prognostic balance pretty effectively. And we can tell this because when we controlled for all of the different covariates that we might worry about as causing a difference in baseline prognosis, the end result actually gave us the exact same relative risk as the crude unadjusted analysis did. And not only that, but when they used the linear mixed model to account for the correlations within the medical centers, that as well really led to a minimal change in the point estimate and minimal change in the confidence interval, which means that the correlations related to the medical centers, the hierarchical structure of the medical centers, actually did not impact the statistical analysis all that much at all. So, in conclusion, it really seems unlikely that the data that we see at the end of the study is impacted by confounding or that the error rates are undermined by the correlated observations.